Hi, everybody. Good morning, good evening, good afternoon. A very warm welcome to all of you to this post-ASH webinar roundtable discussion brought to you by the International Academy for Clinical Hematology. My name is Mohamad Mohty. I'm a professor of hematology at the Sorbonne University and Saint-Antoine Hospital in Paris, in France. And it is my great pleasure to moderate today this post-ASH webinar dedicated to myeloproliferative neoplasm. If you would have asked me 10 years ago to organize such event, I would have said, oh, we may need like maximum 5 minutes because there's nothing ongoing there because except transfusion, of course. But thanks to the advances of biology, thanks to a better understanding of the pathophysiology of these different entities, and we'll speak about each one of these entities under the umbrella of MPN. Now we have seen incredible advances, and specifically the last ASH 2023 meeting proved to be an excellent year for the MPN field. And as you say, in France, it was a good year for the wine, you know. So I guess we'll hear a lot about advances in myelofibrosis, advances in ET, PV, even, I don't know if we will allude to CML, but again, all of these MPNs are really moving very nicely. And of course, please keep in mind that this is a live event, highly interactive, so please don't hesitate to jump in and contribute. And our panelists today are really the superstars, those who are really working very hard to advance the field of MPN, namely Professor Claire Harrison from the UK, Dr. Tania, Jain from the US, Dr. Jean-Jacques Kiladjian from Paris, here in France, Dr. Ruben Mesa from the US, and last but not least, Dr. Naveen Pemmaraju from Houston in the US. And please don't ask me, how did I find this order? It's just by the order of the photos on my screen. Thank you all for joining us for this webinar. And let me start the discussion with you, Jean-Jacques, because you presented in the oral session some very provocative data. So I thought actually to start the webinar by asking each member of the panel what is his or her highlight of ASH. But then I immediately got in mind this oral presentation you had. So maybe we can kick off with you, Jean-Jacques.
Yeah, thank you very much, Mohamad, first for the invitation and for organizing this post-ASH webinar. So Jean-Christophe Yanoto presented at ASH for the IACH working group on MPNs, really interesting data based on a large number of young patients. In fact, as you know, MPN are chronic diseases that go for lifelong. And so we don't really know what is the impact of such a disease when it's diagnosed very young. And we could collect within the frame of the IACH working group about 350 patients diagnosed before the age of 25 with a long follow-up and see what happens to them. And in this cohort of patients, we were able to show first that the risk of thrombosis was increased with hyperleukocytosis. So in this cohort of patients, more than 11,000 leukocytes was associated with a higher risk of developing thrombosis on the long term. The second interesting data was about transformation to myelofibrosis. And what we saw, surprisingly, is that this risk is quite high, 20% after 20 years of follow-up. So if you are diagnosed at 70 years of age, of course, 20%, 20 years later is maybe not so relevant. But when you are diagnosed in your 20s, it means that at the age of 40 or 50, the risk of developing myelofibrosis is very high. And what was really interesting is that we could study the impact of the drugs patients receive during the chronic phase on this evolution to fibrosis. And what we found was first that having a CALR mutation was associated with a higher risk of developing myelofibrosis, in particular for patients with ET. And second, the positive thing is that treatment with interferon seems to completely abrogate this risk of fibrosis. None of the patients treated with interferon developed myelofibrosis. So, of course, this is registry data, retrospective analysis. We have to confirm that, but at least it gives some, I think, new information, especially for our young patients in whom we have probably to select the best treatment able to avoid long-term transformation.
Excellent. Thank you so much, and congratulations for doing this work, because I'm not aware of such work about the natural history of MPNs in such a young group of patients. Obviously, we always claim that we need prospective, larger series, but sometimes it's not easy, and you did a great job. What are your thoughts, Claire, about these findings?
Well, I'm a little bit biased because actually we led this between us. So it's a beautiful example of collaboration that's first and foremost that actually sent us from across the world out as far as actually Taiwan, contributed patients. So this is really important. So it reflects, you know, sort of not just European practice, but wider. I think it's really important, and something we've actually been developing in collaboration again with our patient community is actually a group of young patients. And we do hear this very much from them. Their worry is about transformation and long-term data. So this data is important because it actually gives us something to talk about. It does highlight that rates of transformation are quite high. I think it was 20%, Jean-Jacques, at 20 years. But it also, it's really pointing the way that we should be using, you know, non-toxic drugs, largely less toxic drugs anyway, in a selective way. And so I think this is really another push for us as a field to say, you know, low risk disease is not no risk disease. Any decisions we make now are, you know, really going to potentially impact on our patients. And it's in line with the beautiful data from Cornell, etc. as well. So I think it makes us really think hard about future strategies. And what we want to do, Jean-Jacques, in the future, actually, isn't it, is write some guidelines for the management of young patients.
Yes, exactly.
And include these young patients in this process. So we'll be doing that with the EHA. But also it really makes us think about what are we recommending, who should really be having these treatments. It would be nice to do it by genotype, but we didn't have enough data to do that yet.
So let me push a little bit the discussion and build on this and ask Ruben a practical case. And this is a real life situation. Before ASH, actually, I've seen a 22-year-old patient just discovered with with ET, actually, more than 1 million with CALR mutation. And how would you counsel this patient today based on these data?
Well, certainly the data from Jean-Jacques, I think, and colleagues is very important. You know, first, these patients are not homogeneous. You know, I think, you know, a patient gets diagnosed with ET, you know, they'll look online and see, you know, fairly archaic information that, you know, the median age of presentation for ET is 68 years old. You know, you only use aspirin, you know, blah, blah, blah. You know, most of which really isn't 100% relevant at the current time. And I think we've learned over time that this is an incredibly heterogeneous group of patients, ranging from teenagers to 90-year-olds, with a whole range of relationship as it relates to both their driver mutation and other mutations, as well as whether they really have ET or some early variant of myelofibrosis. So there's a lot of individualized factors in addition to, you know, how they're doing clinically, their symptom burden, and other difficulties, because it is not infrequent that individuals have, limitations from the high platelets, including headaches or fatigue, sometimes difficulties with concentration or cognition, so there's a range of things. Now, it's important with the data that Jean-Jacques had showed to realize that these were patients in which it had been decided that they should be on cytoreductive therapy. So again, that is a selection piece, that they were already chosen to be on cytoreductive therapy. So may or may not be fully applicable to the patient that you mentioned. Now, 22 with calreticulin, I would first start with such an individual to really see how they're doing clinically. Because in our current guidelines in the US, and I think mirroring similar in Europe, if they have no signs of acquired von Willebrand disease, if they're not overly symptomatic, they still may be managed with observation or a baby aspirin. And there's some, controversy again, is aspirin necessary or appropriate in this kind of very low risk group of folks. Now, I will share in my experience, when you really start chatting with these patients, there are not that many of them that truly are asymptomatic, and then again, it becomes a discussion whether there's a value to considering, other interventions such as cytoreduction or not. But if they were truly asymptomatic, no issues with bleeding, no other somatic mutations, then I may be more conservative. In people like this, I do think it's helpful having that baseline, both bone marrow biopsy. I think that's a really key piece. Are they truly no features of early MF? I see in the US, I'm sure in France, perhaps less so, but in the US, it is not uncommon patients have had molecular phenotyping, they know their CALR, they have a high platelets, and they're labeled as having ET without having had kind of the full diagnostic workup, which we realize, could be wrong.
It's becoming more and more frequent. I can assure you. Recently, I have seen an NGS, and the patient couldn't find the CBC, but that's another story. Tania, what is your take on these data?
Yeah, so this is what I would call a very important study, and sort of reflects the power of working together, because this is something that we struggle with, right? I mean, there's over the years, we've piled up data in the context of a run-of-the-mill myelofibrosis or MPN patient who, as Ruben alluded to earlier, are more advanced in their life. And this is whenever you see, or whenever I see a patient under 30 years of age, I have to think about it. I have to take a pause and think about it. So very intriguing data, and probably, and hopefully, maybe you can correct me, Jean-Jacques, it reflects on some of the use of some of the more widespread use of interferons in the cohort, right? Which is probably why you're seeing the difference, contrary to what one would usually expect between CALR and JAK2. You're seeing more progression in the context of CALR, and perhaps you're not seeing as much in the context of JAK2 because of interferon use. Is that what your study results sort of aligned with, pretty much?
Yeah, you're right. And to comment also on Ruben's about cytoreduction in these young patients, we were surprised to see that about 65% of so-called low-risk patients indeed received cytoreductive drug, although according to current recommendation, they shouldn't have. They should stay only on aspirin. So we don't exactly know why, probably because doctors are frightened to let very young people with elevated platelets or very high hematocrit on phlebotomy only. And the use of interferon was about around 20% in patients with ET, and up to 40% in patients with PV in this study. So yes, quite a large proportion according to the current authorization label of the drug. I mean, more patients with PV received the interferon than ET, but still 20% of those. So yes, clearly we need maybe as Claire mentioned, this work we're going to do about trying to develop guidelines for this specific population will be important to collect all the information we have and put this data on the table.
Yeah, I think
Jean-Jacques,
sorry.
sorry.
No, go
Jean-Jacques,
ahead.
one last question before we move to the therapeutic aspect from Dr. Tiziano Barbi. What was the follow-up in the study? I guess you presented this, and do you have data on overall survival?
Yes, there was no difference on overall survival, and I don't remember exactly the median follow-up, but Claire, you remember?
I think the
it's
median follow is about 15 years.
15 years, yeah.
There were actually only 4 deaths.
Mm-hmm.
Right? And many of those were probably looked like they were related to transformation because they looked like they were graft versus host disease. So unfortunately, they were transplanted. I think it's really tricky. We think that calreticulin, is a benign mutation. We even have this discussion about they don't need aspirin, blah, blah. But actually, the other thing that came from that study was that calreticulin mutation was a strong risk factor for myelofibrosis. So the new calreticulin therapies, which we saw nothing of really at ASH, that's what I'm looking forward to hearing about next year.
Wonderful. I'm glad you mentioned myelofibrosis because this is going to be my next chapter for this discussion. Myelofibrosis was almost like a hopeless disease, but now we see more and more. So probably we're diagnosing more of these patients, because of age, we are seeing more. And we've seen now advances in the treatment. So what are the highlights from ASH regarding myelofibrosis? I don't know who's going to take it. Naveen.
Thank you, Professor Mohty, for having us together. I absolutely love this group of world all-stars that you assembled. The ASH meeting for us was a big meeting for the MPNs, as you started to hear with the MPN-AYA discussion here, which will be very important all around the world. Myelofibrosis was featured mainly by the introduction of combination, so dual therapies for myelofibrosis upfront, maybe for the very first time, where you have a JAK inhibitor and a novel agent, and there were 3 such presentations. The 3 are interesting because they represent 3 new pathways that are not yet FDA approved, and they're being combined with JAK inhibitor for the first time. The first one is the one I'll comment on, which is ruxolitinib plus navitoclax, which is a BCL-XL inhibitor. I'll ask Professor Harrison to comment on the second one, pelabresib, which is a BET or bromodomain inhibitor. And then even a third one, which is earlier on, only phase 1 data, selinexor, which is an XPO1 inhibitor, but now quickly already into a phase 3 large study. So Professor Mohty, for this first one, the ruxolitinib navitoclax, which I had the honor of leading, we did a large study, 252 patients, double-blind, placebo-controlled, randomized upfront study, worldwide study, ruxolitinib plus navitoclax, the new agent, versus ruxolitinib plus placebo. Mainly intermediate 2 risk patients, so 80+% in both groups with a 10 more % high risk, only a couple of patients who are intermediate 1. That'll be important as we look at the 2 studies. The primary endpoint for the study was just one endpoint, SVR35 at week 24, our traditional endpoint. Comfort 1 and Comfort 2, which was led by Professor Harris, Professor Verstovsek, was in the order of 30 to 42%, I should say. And then here in this study, the SVR was higher at 63%, so 60+% SVR 35. And so it was a successful study, primary endpoint. But as always in our field, that wasn't the only story. There was a secondary key endpoint for both of these studies, which was symptom response, and the Rux navitoclax did not. It did not meet statistical significance for that. Now, both groups had lowering of the symptom burden, including the experimental arm, navitoclax, but the control arm had a slightly higher numerical, so no significant p-value. So in that setting, you have a primary endpoint that was met, secondary not. Median follow-up is only 15 months, so we don't have data yet on overall survival, PFS, and some of these markers. And so I think the conclusion from this first large study is that you can safely and feasibly give a novel agent with JAK inhibitor upfront, but that even though the spleens were met, the symptoms were not clearly met at this time with p-value significance. And so I'd like to turn it over to Claire for her comments on the pelabresib study also presented at ASH. Claire?
Thanks so much, Naveen, and we've worked together on navitoclax. So it was great to see these studies both being presented, and I think huge congratulations to the investigators and the teams for pulling this off, and the particularly pelabresib data literally was sort of hot off the press coming into ASH. So just for the audience, in case you're not familiar, both studies have got a second agent, which has got a lot of logic in terms of its addition, navitoclax, as you know, inhibiting apoptosis, and linked strongly to the JAK2 pathway, and then pelabresib with its NF-kappa B inhibition and effects on megakaryopoiesis, both agents showing efficacy as a monotherapy and add-on as a second-line therapy. And then with the pelabresib study, which was called Manifest-2 and presented in a second session in true ASH style, 15 minutes walk away across the Congress. So the design of the study was quite similar, as in it was a placebo-controlled blinded study. The endpoints were similar, but the study was larger. So we had 430 patients. The second largest study ever in myelofibrosis. So Ruben study Simplify 1, 431 patients. This study included patients who were JAK inhibitor naive, as did the other one. And then, but for the pelabresib study, we were allowed to include intermediate 1 risk patients. And as you look at the demographics of the patients in the study, as Naveen, you nicely alluded to, we had almost 60% of patients in this study were DIPS, prognostic scoring system, intermediate 1 risk. The rest were mostly intermediate 2, and there were few high-risk patients. So we should have a discussion about where are the high-risk patients, because neither study recruited a lot of high-risk patients. Again, the readout from this study was very positive in terms of spleen response. And this is important because it's strongly linked to survival benefit for patients. So 65.9% for pelabresib, 35.2% for ruxolitinib, so highly significant. But again, this study also missed on both of its symptom endpoints, but there are some important differences, I think, between the two studies, which we can debate. But in terms of the symptom improvement, the trend was towards an improvement for pelabresib. So the p-value here on an absolute TSS difference, which is slightly new endpoint for us as a continuous endpoint, the p-value was 0.0545, so close. But for TSS 50, again, which is our more traditional endpoint, the study didn't hit significance. But again, there were 52.3% who hit that endpoint for Pela plus Rux versus 46% for ruxolitinib alone. I think the other interesting thing with the pelabresib study was we actually saw more adverse events in the placebo plus ruxolitinib arm, so very well tolerated. And we also saw anemia benefit, which is some data that hasn't emerged yet for navitoclax. And if you looked overall at the patients who had a benefit for both TSS 50 and spleen, it was 40% for the novel combo versus 18% for the placebo arm. So there's kind of doubling of patients who achieve both SVR 35 and TSS 50. Some novel and interesting and important biological data. The hemoglobin data is also important, but I think it begs a discussion about what is important with regard to symptoms. For me, if I add a second drug, I don't expect the patients necessarily to do better for symptoms. I think you have to think about tolerability.
Okay, so just to clarify to our audience, so pelabresib is a small molecule that inhibits bromodomain and extra-terminal domain proteins, which may downregulate some of these genes involved in the malignant process. So that brings me maybe to ask the other members of the panelists about the choice of the endpoints in these trials, because at some point, well, obviously, if I'm considering a myelofibrosis in an 85-year gentleman or lady, definitely improving the symptoms and being transfusion-free is something crucial. because anyway, at age 85, you are already beyond the life expectancy in a Western country. But assuming you have a myelofibrosis in someone who is age 60, so the question is also about improving survival, not only the spleen or the transfusion. So what are your thoughts? How this is going to move forward beyond? Obviously, I know that we need pragmatic trials to get the drugs approved, but at the end of the day, we want the patient to live long and well. Tania, what is your take on this?
Yeah, thanks, Dr. Mohty. So, both of these were critical trials in the space. We'd been waiting for what comes out of these for a while. And similarly, there is selinexor phase 3 data that'll hopefully reach some maturation by next year. And other drugs in the pipeline. And I think this question applies to all of them. And you rightly pointed out, when you're thinking of upfront therapy in a patient who you're trying to potentially cure or improve survival at the very least, it's hard to imagine that SVR35 and symptom improvement alone are necessarily the most established, validated endpoints to correlate with that. In addition to that, when you're adding a second agent to an established single agent as a frontline therapy, you're adding cost, you're potentially adding toxicity, and all those things need to factor in as we think about the endpoints. So I 100% side with you that there has to be something along the lines of survival or a path to cure that needs to come out of these. And the spleen responses are great, which was the primary endpoint for both of these studies and remains to be for most of the other phase 3 that are in the pipeline. And symptom improvement too, but I don't know for sure if they reflect the curative potential or the survival improvement for these strategies. The TSS especially, because it's a relatively, it's a very well-established outcome or a parameter for MPNs. But there is an element of subjectivity in TSS reporting, which we cannot do away with, which probably part of it comes from the side effects from the second agent or the combination in general. So how do you tease those things apart is very critical as we interpret this. Both of the agents have clearly shown activity, right? There's clearly activity both with navitoclax in the prior studies as well as this. Same thing with pelabresib with an added sort of incentive of anemia improvement potentially in a fraction of patients. But how do we now establish that both of these or either of these have an advantage in terms of making people live longer? And I think that is where we need to work on to identify what are those surrogate outcomes that we can establish that can help us bring these therapies to patients faster, the ones that have survival advantage. And I think that is something that we'll need to think about more and more as we design these studies, especially as we think about taking them to the FDA and things like that.
Okay, thank you. So let me designate or ask Ruben as a designated volunteer to design the perfect optimal trial today for these patients with all the available drugs. What do you think, Ruben? We need your microphone.
There's always the balance of, how do we plan for the future while still taking care of the needs of the present? For my center, we're currently undergoing our own planning process. And again, how do we, take adequate care of the people that are rolling in the doors today while still trying to innovate for the future? What is that ratio? And in many industries, depending upon the level of innovation, that can range like a 70-30, where, you got 70% of your energy on the day-to-day and 30% kind of looking forward. And this, I think, is a very similar analogy. In the end, there's only two endpoints that really matter. Patients can live longer or they can live better. And the reality of 2024 is we do not have a good surrogate marker of what leads to a prolongation in survival in MPNs. We clearly desire this, but we do not. So I think the reality that we have faced, one, the endpoints are not the problem. The problem has really been we've not had therapies that have had more efficacy. I think the endpoints flow. Once we see greater efficacy, we'll know how to readjust our endpoints to things that matter. I do think as well, the economics of trials has led to really a premature readout to make trials feasible. The 24-week model that really evolved from the COMFORT studies with ruxolitinib, which is a very active drug compared to placebo, 24 weeks was plenty. I think the problem is that endpoints that may evolve to be relevant, we may not be able to read them out at 24 weeks, in a disease, that is as chronic as myelofibrosis, without having really very, very particular subsets. We have a whole range of candidate surrogate endpoints, but they have not been proven. A decrease in fibrosis, decrease in allele burden, on and on. They all sound nice, but none of them really have been proven to be longer. So I'm mindful because, again, we're treating patients in the clinic today, that have genuine difficulties with their disease, and I'm reluctant to really have what are experimental endpoints kind of drive their therapy until they kind of have further validation. So I still stand by the clinical benefit that we've seen with spleen and symptoms as a way of assessing clinical benefit, always balanced against a toxicity and the evolving pieces that we have. I do wonder, as we evolve, in my ideal world, I think we will try to leverage more real-world evidence. We have over a decade of which ruxolitinib was the sole therapy that was largely used. I don't think we need to run a dozen phase 3 trials with ruxolitinib as the single agent comparator. We know how ruxolitinib behaves. I mean, there's a tremendous amount of data to be able to do that. I'd hope, and as I've shared with folks, if there's a scientific gap that exists in MPNs, is understanding why do patients progress, and then how can we really measure that? Because even in therapies that we have that have efficacy, like Jean-Jacques' data certainly is very provocative, in some ways confirmatory of anecdotal experience, that interferon may help to decrease the likelihood of progression. But we don't really know what the ideal dose is. We don't know when managing the individual patient, do we need to increase the dose intensity to maximize that? Are we maximizing that progression-free survival benefit? Have we already gone beyond that? And now, they've lost that benefit. So I think there's a real scientific gap that remains. So in my eyes, I don't think we are really there yet to scrap our current endpoints, unless if we're willing to, in an experimental way, really follow patients for longer. But again, that's going to take time. I think in the JAK inhibitor naive patients, as we saw with both the pelabresib and the navitoclax study, these patients, they tended to be more intermediate risk. They tended to be less severely impacted than the COMFORT trials, and appropriately so, because we don't have the same kind of landscape that we did before. I'd say, really drilling down on the discovery science as to what are the mechanisms of progression, so that we don't have to really, make really empiric decisions in many ways. I do think the regulatory piece is just so critical. As long as we're tied to this model of a 24-week readout, on trials, it's going to be very difficult to see, a delta, And then final comment, strongly agree with Claire. The idea that combination therapy has to both beat for spleen and symptoms and other points, that was really a very arbitrary decision. And to be honest, it was not one that came from treating physicians or experts in MPNs. It was really kind of a unilateral US FDA decision, really without any input. I think all of us would have had great concern with that sort of approach, realizing that 2 drugs are likely to potentially, not be superior for symptoms, or that a second drug may give low-grade toxicities that could blunt a symptom response as well.
Thank you, Ruben. And I think you already alluded to one question we had from Dr. Welter about safety. Claire, you answered this. And the issue of the endpoints was brought by several questions. For instance, Dr. Ishtagari, I hope you got your answer. So you mentioned the biology of the disease. And here I would like to give a question from Dr. Hoshman to Jean-Jacques. Because obviously, these diseases, although we call them the same myelofibrosis or whatever, maybe there are some subgroups, and now we're dissecting almost everything in hematology. And actually, at the end of the day, it would be very difficult to run phase 3 randomized trials if you dissect into small entities. And the question is about the genomics, for instance, in MPNs. And let's focus on myelofibrosis. What is the value of TP53 mutation or any other variables that can play a role in the prognosis, Jean-Jacques?
That's a very important question. And obviously, this also impairs the ability to have unified endpoints because, as you mentioned, these patients are very heterogeneous. Even for the phenotype, you have a group of patients who are very cytopenic. So how can you treat them the same way than those who are proliferative, for example? We discussed symptoms, spleen, etc. But anemia, transfusion dependency are also really relevant issues for our patients and maybe should be assessed. And what we know from this heterogeneity is that it translates probably in the molecular landscape of these patients. Compared to CML, as you mentioned, it's very different. There we have a straightforward disease with one translocation in the vast majority of patients. Here, we have at least, yes, surely 3 driver mutations, but on top of these, we have many, many other additional mutations, and among them, TP53. So just to focus on TP53 for the moment, what we just very recently published is an animal model where we induced the loss of TP53 in the JAK2 V617F context, and indeed showed, and this was also previously shown, that the loss of TP53 alone is probably not sufficient for inducing a rapid transformation to acute leukemia in steady state hematopoiesis in these diseases. The second maybe interesting finding is that the loss of TP53 seems to give kind of resistance to interferon, for example, because it affects a lot of genes, this loss of TP53. Half of them are involved in inflammation, etc., and may alter the response to some drugs. So we also have high-risk mutations that were quite well identified previously, including IDH 1 and 2, EZH2, etc., and A6L1. Again, just to highlight the difficulty in this disease, although A6L1 often comes out as a high-risk disease, in the French cohort of patients, we were able to show that when A6L1 was the only additional mutation, indeed, it didn't worsen the prognosis of this patient. It was worse in the prognosis when it was associated to other mutations. So we have here a lot of work to do still, and maybe, as it was mentioned by my colleagues before, we have to tailor our treatment, the so-called individualized therapy, etc. I think fully will apply to these diseases when we will have enough drugs targeting specific alteration we can find in our patients, like it's the case, for example, already for IDH mutations, because some of these patients who have accelerated phase and IDH mutations respond to the combination of IDH inhibitor, JAK inhibitors, etc. So we will probably in the future, we will have drugs that are able to target these additional poor prognosis mutations. Maybe we will improve our results, obviously, for the patients and also the design of clinical trials.
Wonderful. Thank you very much. And Jean-Jacques, you made my life easier because you anticipated on a question from Dr. Virgilio Alberto Salinas Rodriguez from Peru. He's very loyal to the ICH activities, who asked about actually ASXL1 in the pathophysiology of these diseases and take this opportunity to say hello to all our friends in South America and all those of you following the ICH activities. Let's move now into a different topic, and it's going to be for you, Naveen, to start. It's about BPDCN. I know it's something very close to your heart. You have contributed a lot to bring this very rare, terrible entity, I would say, into the podium. So what's new in BPDCN? How should I treat my next BPDCN? I think I see usually 1 or 2 per year. So what's going to be the menu for the next case of BPDCN?
Sure, thanks for asking. I think it fits nicely in our MPN and AML discussions, as we have been the leaders worldwide in these rare and ultra rare diseases. I think that as we've seen with systemic mastocytosis, just in this last ASH, which had 3 oral presentations, the 8p11 syndrome, pemigatinib, a drug approved based on less than 30 patients, that our colleagues, some of whom are here around the world, we really focus on patients that really only have maybe 200, 500 cases a year. The BPDCN is one, as you know, and you've followed and supported me throughout the last couple of decades, 2 or 3 major discoveries that I'm pleased to share. So for everyone out there, it's a rare acute leukemia subtype is how we regarded it now in the latest classification under histiocytic and dendritic neoplasms, blastic plasmacytoid dendritic cell neoplasm. So it is a skin, bone marrow, blood, lymph node blood cancer. So it affects kind of a lymphoma leukemia hybrid presentation. But the 3 major findings to present to everyone that have really changed our practice is, number one, our group and others now have confirmed a shockingly high rate of central nervous system involvement. So 20 to 30% of cases will have CNS involvement, usually demonstrated by the LP lumbar puncture positive. So we recommend 8 lumbar punctures for all patients, so 2 for the first 4 cycles, regardless of targeted therapy or cytotoxic chemotherapy. Number 2 development has been the CD123 therapies. Our group pioneered the first and only approved drug thus far, known as tagraxofus for TAG, CD123 diphtheria toxin payload. That was exactly 5 years ago. And that's been a successful drug, although it has some toxicities that have been clearly documented over time. As a single agent can put a lot of people in remission, but then there's relapses after that. So we've been working on combination therapies. And I'm proud to tell you there's a 2nd generation CD123 drug under development, which is the pivekimab sunirine or IMGN632. And that trial I presented at the EHA meeting as oral presentation. So we'll await those data. And finally, Mohamad, the last development in BPDCN is the still curative potential. It's a chemo-sensitive disease, CD123 targeted disease, BCL2 sensitive disease with VEN, but also allogeneic stem cell transplant. So just to put out there that allo transplant has remained a cure. There was a large CIBMTR study showing that we have used auto transplant in some older cases, skin limited, but mainly I favor the allo transplant, and then immunotherapy and CAR in the exciting but infant stages. So I think rare disease that we've shown that we got a drug, US and EMA FDA approved, and that we're now working on 2nd generation and combinations to hopefully once and for all cure this rather deadly disease. Mohamad?
Thank you, Naveen. Great summary. So I have a practical question which has been raised by several colleagues. So Claire and maybe Tania, Ruben, Jean-Jacques, whoever wants to comment on this. If tomorrow I have a relatively young and fit patient, I know usually they are old and frail with comorbidities, but if you have like a 62-year-old patient who's fit, no comorbidities with BPDCN, what is your current approach? Would you still favor high-dose chemotherapy for induction, bridging to allo, or are you moving into these more targeted therapies? Sure. Irrespective of approvals, what would be your thought on this?
Yeah, I'll answer on behalf of the group. I think what this is actually an important question you asked. So I've convened a couple of different consortia. In North America, we have the NABC, the North American BPDCN Consortium, but that's really just Canada, Mexico, US. And then a more worldwide consortium with you and others, and then our colleague Gavor Tamamian Mohamad in Armenia. So what we found is that the CD123 drugs are only available really in America and some parts of Europe, not even widely available, have some toxicity, have some cost and availability issues. Dr. Jain, as you nicely mentioned on some of the earlier comments. So from a worldwide perspective, it's a fascinating disease. It is a hybrid between AML and ALL, and it's highly lymphoid sensitive. So our group has published work with the Contorgent hyper-CVAD regimen. We add ven, 80 to 90% response rate. Mohamad, your group and others in France have shown that the older ALL lower intensity approach. So ALL-based chemo as a first approach. Secondly, it is myeloid sensitive too. So I know a lot of groups are still using AML-based regimens, although I use that second line and beyond. Thirdly, the venetoclax. So it is a BCL2 dependent. So if you have access to that. And then of course, clinical trials and CD123 therapies. For the future, once the 123s are available to everybody, I have 2 active trials now. So TAG, AZA, VEN, so a triplet. So CD123, HMA, BCL2, very nice response rates in older unfit patients. And then TAG, hyper-CVAD or mini CVD plus VEN. So giving essentially, as you and others, Mohamad, have done in multiple myeloma, if you'll allow me to use that very nice example, BPDCN has a very one year or less overall survival in relapse refractory. So to move to more total therapy, frontline combinatorial approach, which uses chemo and or HMA, CD123, BCL2, and CNS prophylaxis, allo transplant for those who need it. That's what I think could be the cure for this rare disease.
I like the concept of total therapy to cure more patients with BPDCN. Wonderful. And we owe this concept of total therapy to Dr. Barbara Logie, actually. It's a very, very old story, and we need to acknowledge it by any means. Okay, let's move to PV now. So after this ASH meeting, I heard a lot of, and it was a bit confusing for me because PV, for me, it was, okay, relatively easy, straightforward disease to handle. And now we have Ruxo, we have interferon, we have maybe other options. Any thoughts on PV, how to manage PV, how to stratify the risk? Who wants to start?
Maybe I'll jump in. So with PV, I think kind of building on the earlier discussion, historically, it had been managed really to curtail the risk of thrombosis and bleeding. And really, most of our historical guidelines, phlebotomy, aspirin, and the selective use of cytoreductive therapy really had its endpoint trying to decrease the risk of blood clots and bleeding. And I think over time, we've recognized that is really a partial approach. One, patients can be symptomatic, sometimes significantly so. And two, there's a variable risk of concern really for progression. And it's been, again, difficult to weave both of these pieces in. Now, Jean-Jacques, who's obviously here on this call, really has been, career-long leader in trying to push the envelope of therapy for PV, in particular as it relates to the role of interferons. And I think we've recognized interferons with the work of Jean-Jacques, but clearly of those of Dick Silver and Harry Gilbert and many others in the past, that interferon really had a role with the ropegylated interferons approval, with the efforts of AOP and Heinz Gisslinger and others being more recent, but being a very helpful addition, in part because the drug has been really specifically developed for this group, whereas the pegylated interferon alpha 2A, which we've largely have used, has always had less enthusiastic support from the manufacturers of the drug to try to get approvals, in Europe or elsewhere, which has been a limiter in terms of reimbursement and others. Our U.S. guidelines, of which I co-led with colleagues from around the U.S., had both hydroxyurea and long-acting interferons as frontline medical therapy for those individuals requiring cytoreductive therapy, which were individuals that were higher risk, age over 60, prior thrombosis, but also those with cardiovascular risk, inadequate control by phlebotomies, not tolerating phlebotomies, inadequate symptom control, or flipping around in an easier way, those that we don't use cytoreductive therapy, those individuals that really are low risk and truly asymptomatic. I'd be very curious, Jean-Jacques, who really, he and his colleagues in the laboratory, both in his lab and colleagues at Hôpital Saint-Louis have looked at a range of different things as it relates to the biological impact of interferons. Jean-Jacques, as things have evolved, what do you think the goal is in PV? Is it still historically prevent thrombosis and bleeding, or do you think we really are ready to say that progression-free survival is one of our primary reasons for treating PV?
Yeah, you're absolutely right. I think we are shifting the paradigm of treatment in this disease to more, let's say, disease-modifying therapies, because we have at least one probably that is interferon, but maybe others. And for example, with Claire, we are testing the role of ruxolitinib upfront, not as a second line, but as first-line therapy in a large clinical trial in France and UK. Called Mithridate. So yes, I think we are trying to now have a more active strategy in this patient, thanks to Professor Barboui and his trial, so-called low PV study, in which he tested the addition of a low dose of raw-peg interferon to the phlebotomy aspirin regimen in low-risk PV patients. And he showed as quickly as for 12 months, the first endpoint, that the addition of this low dose that is quite well tolerated induced a higher rate of maintaining the hematocrit below the 45% threshold that is associated with higher risk of thrombosis, and also already able to induce some molecular response with a reduction in the JAK2 allele burden. So, and this was also acknowledged by the most recent European Leukemia Net, the ELN guidelines for PV, where we acknowledged that a subgroup of so-called low-risk patients, according to the risk of thrombosis, deserved, in fact, a cytoreductive therapy with interferon or maybe other in the future. But yes, more and more, I think we need to treat those patients, especially in the light of what we showed in younger patients. If you look at the 10, 15, 20 years of evolution of these patients, a proportion of them will evolve to fibrosis, to accelerated phase, MDS, and eventually acute leukemia. So yes, we have to probably switch our goal of treatment. But Claire probably also has some views on that.
Claire?
Oh, I definitely agree. I think it's really interesting how you started this session, Professor Mohty, 10 years ago, MPNs. I think it was maybe more like 15 years ago. But anyway, time goes fast. I think we're going to see changes across all the MPNs. I definitely think, there's a beautiful piece actually written in Blood towards the end of last year by Rajit and John Mascarenhas and others challenging us on why are we using venesection, aspirin, and probably also hydroxyurea for patients when we know we have other therapies that are probably less toxic. Iron deficiency is not without toxicity and can potentially change course of disease. So I'm also really interested in how we integrate molecular data. But I think, it's probably better to treat a disease in its earlier stages before it becomes too complex, but we're lacking this data. I'm looking forward. We finally got the study open in France. We open a study, then there's Brexit, then there's a pandemic. But these kind of, academic driven studies are sometimes really important, like your BPDCN studies, Naveen, the MAGIC PV study.
And your MAGIC PV study, Claire, and JCO.
Yes, showing the long-term data and the benefit or not of molecular response. Maybe we'll catch up, but these things take time to show, don't they? But I really think there's a sea change coming, and even really interesting whether we should be managing JAK2 positive ET in the same way. Maybe
but
that's
Claire,
wow.
Here at the IACH, we are. Our mantra is hematology without borders. So we don't care about Brexit or Frexit or whatever exit.
No. I know. It's just the logistics of then opening a study between my tiny insular wrong island and the rest of Europe, which is amazing, right?
We are very proud having you with us, and we're working all together hand in hand to improve the outcome of these patients. Tania, one last word on PV before we move to something else.
Yeah, I think I like your point. I agree with all the points made so far. Besremi has certainly, taken over the practice in terms of the early MPN, especially with the JAK2 mutation. I think Ruben had brought this up, or along the lines like, is bleeding or VTE, venous thromboembolic events, are those enough as endpoints? And I was thinking about like the usual discussions that we have with patients, and I give them a short-term goal, which is a VTE prevention, and a long-term goal, which is disease progression, which I don't think we have a good grasp yet, but I think we're moving along those lines for sure with drugs like interferon, and potentially even, we'll see how the ruxolitinib data fares out, and others, the hepcidin targeting agents and things like that.
Wonderful. Thank you very much. Although the treatment moving very rapidly, because we acknowledged earlier the concept of total therapy for Dr. Barloghi from the mid-80s, we need to acknowledge that nobody until now has challenged the concept of myeloproliferative diseases pioneered by Dr. Damashek in 1951. So this is quite amazing. Okay, we have a question which will open a broader topic, I think, and this is about SHIP and MPNs. There is a lot of excitement about SHIP, and actually, I must confess, it's very difficult to know what to do with it sometimes, especially when you just finding it by chance. I know some hospitals and teams are opening SHIP clinics. I don't think it's a tradition for us yet here in Europe in general, but are there any thoughts, any links, any ideas about the issue of having SHIP and evolution to MPN? Naveen?
Yeah, I think it's going to be one of the big topics of the coming decade, and I think you set it up perfectly. I'm going to ask Jean-Jacques to comment as well because of his nice early observations. But interestingly, for our viewers out there, JAK2 is essentially the fifth or fourth most common CHIP marker. And as Jean-Jacques and others have shown, many patients are maybe called CHIP, but they're actually already evolving to MPN or already have an MPN by virtue of thrombotic risk, et cetera. But Mohamad, you make two huge points. One is, can we separate out the worried well patients who are not yet patients? So you have a precursor of a precursor of a precursor, versus can we then, if you'll allow me to use for this conversation, high risk CHIP or medium risk CHIP, those who have a higher percentage chance of going on to not only develop an MPN as this discussion, but high risk of MDS and AML. In addition, there's cardiovascular risk factors that actually may be the more pressing issue. And I have begun to work with cardio-oncologists much more than I ever thought, in a good way, about this exact topic. I think that some of these mutations are very common in our population when you check TET2, BNMT3A, ASXL1, that are already oftentimes high-risk mutations in our patients with known MPN, but you can have it as CHIP. So I'd like to divide our comments into these three things. There could be a low-risk group that just needs observation, cardiovascular risk protection, maybe nothing. A medium to higher risk group, which the clinical trials will look for chemo prevention and other strategies. And then guys, maybe a super high risk group who's already transforming in front of your eyes, who may require therapy. But Jean-Jacques, if it's okay, I'd like to turn to you for your comments.
Yeah, sure. Thank you, Naveen. And indeed, with Claire, we made the comment in the New England Journal in one of the first studies about CHIP, saying that, of course, maybe it's a CHIP, but did you really collect the information to be sure it's not an MPN? And this was missing a lot in the first studies. So times have changed, but I should say that we have this problem now for several, in particular for patients who develop thrombosis, as you mentioned. And we have now a lot of patients, that we are kind of reference center for splanchnic thrombosis. So what we see now, referred by our pathologists, are patients with splanchnic thrombosis and a very small JAK2 VF mutation, 1%. What is it? Is it a CHIP? Is it an MPN? These patients had a thrombotic event, so should we treat them or not? So I think that the field is completely open, and of course we try now to collect more as much information as possible, doing the bone marrow biopsy for these patients, doing the NGS, looking for additional mutations that sometimes are hidden behind that. So we need, I think, more information. And today it's very difficult to give some guidance on how to treat or not these patients who often have normal counts, normal blood counts. So what is the target of treatment in these patients if you start something? So very difficult issue, but I will let Claire and Tania maybe comment on this.
I'll make one comment that at the very least, we know that the CHIP world and the MPN world have a nice overlap in the fact that they're both pro-inflammatory conditions. And when they exist together, what does it mean, right? I don't think we know the answer, but biologically, it's scary. It's not good, probably, right? I mean, high cardiovascular mortality or morbidity, high thrombosis risks, and so forth. So I would love to see in the coming few years studies that are probably along the lines of, these CCUS studies that we're seeing emerging using anti-inflammatory drugs in these patients with the idea of delaying progression. And I think we're certainly at a place in the MPN space where something like that using, there was data on IL-1 beta, how that modulates the JAK pathway and other cytokines that we know of. And I think that's where we need to start thinking and pulling in this CHIP story in terms of how we target these coexisting pro-inflammatory conditions.
Ruben?
I think it's key that we're not overly siloed in this analysis. Think about kind of broader evolving themes around health. So one, there clearly is a group that, quote, have CHIP, but they clearly have evidence of an evolving myeloid neoplasm. So I think those we have to separate out, that again, in the MDS world have, a unilateral lineage cytopenia, what have you. But in terms of CHIP overall, there clearly is this overlap with the risk of cardiovascular disease, a lot of research going on with the mechanisms and process of aging. There is discussion of the interplay between CHIP and Alzheimer's disease, the metabolic syndrome and others. So I think that this is an area where we have to think, we sometimes get overly siloed. We train as hematologists and then really have kind of blinders on in terms of what we're doing, but this is an area I think we need to really think a bit more broadly. I think we also need to be a bit cautious in terms of jumping in with big, expensive medical therapies. I think, again, separating out what we know versus what we don't. I've had patients come in with CHIP, that want an allo transplant, and clearly it's a long discussion as to why we're not going to do that, but there's folks out there, again, even on trials, do we give them azacitidine, other sorts of things? Again, I think we're completely shooting in the dark, and that we don't really have any evidence yet that early intervention of CHIP, is a prudent therapeutic decision.
Maybe I could
I'm
comment.
glad, Ruben, you brought this issue because we're treating patients. We're not treating mutations. We're not treating abnormalities, and we should never forget about this. Claire?
I just wanted to point out the irony, team, that we're having the discussion about a patient with an established hematological malignancy. Should we escalate treatment above aspirin and phlebotomy? And here we are talking about throwing therapies at someone with a CHIP mutation, just pointing out an irony there. But I also want to just draw back and talk about, we talked about Bart Barloghi and the complete approach, but we mustn't also forget that for patients with PV, ET, low risk MF, and this is something that came up at ASH, we need to think about inflammation, nicely mentioned by you, Tania, and from cardiovascular risk. There was some beautiful data about machine learning at ASH highlighting this for our patients. And Jean-Jacques and I have had a lot of discussions about between our centres, how do we look at vascular risk, etc. And I think that's something that we really neglect for our patients, also for ourselves, at our peril, really.
Now, wonderful, and I like this because obviously that explains, at least in part, the success of ruxolitinib in all of these diseases, because this is like the new fancy modern aspirin, actually. And obviously, in terms of aging, I'm sure it's going to play an important role. Okay, we're reaching almost the end of this roundtable, fascinating discussion from past, present, and future, with the discussion about SHIP. Here, I'd like to ask each of you about your wishes, your thoughts, what's going to happen in the field for the next, let's say, 5 to 10 years. So if you want to be very ambitious, 10 years, if you want to be realistic, let's see, 5 years, because it is recorded, by the way, and guys can watch it on demand. But we keep it, on the website, and then we can watch it again 5 years to check whether you got it right or wrong. And we've done this exercise recently because the first webinar of the IACH was in October 2018. So we had some good follow-up on some webinars, to see the evolution of the field. Jean-Jacques.
Yes, just maybe I can start with there's a disease we didn't really talk about, it's essential thrombocythemia, where nothing happened for decades. And here we have new hopes. We have a drug that is tested in this field, completely new, bomedemstat, that is an LSD1 inhibitor. And I would say beyond that, we have also CALR mutation as a target for immunotherapy. And this is completely new in this field. So we have trials ongoing with either antibodies, monoclonal or bispecific antibodies that are coming, and even vaccination. So I think this is a completely new avenue for the treatment of MPNs, and that is now open. And I hope that we will have some very exciting results next year, probably at ASH, or maybe a bit later. But this can be a new challenge for those patients.
Excellent. Thank you, Jean-Jacques. So we'll definitely need to address this more in depth next year. So
I'll just make a comment. In fact, there was a presentation on targeting JAK2 this year. So, last year it was targeting CALR. This year it was targeting JAK2. So I think the MPN field is finally entering the era of true molecular targeting in the therapeutic world.
Interesting. Now I realize, because CALR mutation was described in 2013, and the targeting came like 10 years later. Incredible.
Right. Perfect. Mohamad, I think I'll add my predictions since this is recorded. I love the JAK2 mutant and CALR mutant, as Jean-Jacques and Tania are pointing out. So mutant-specific therapies, we're already seeing them go to the clinic. Immune susceptibility of MPNs. We tried the Nivo and IPI, the general immune therapies, maybe not as much clinical success, so hoping for more on this CALR-directed neoepitope approach. My 2 other predictions will be post-MPN AML. We didn't get a chance to talk about it much here, and our AML colleagues don't talk about it much there, and that's because those outcomes have been abysmal for our patients. Many of those patients have not been included on the traditional clinical trials, such as CPX-351, which is approved for secondary AML, but didn't include our MPN patients in initial studies. So new pathways, new targets, and new combinations. And then finally, Mohamad, the combination therapy approach frontline, as Claire and I presented to you in the group, although the symptoms may not have hit, I still have high hopes for not only those 2 drugs, that's navitoclax, the pelabresib, the future drugs, Dr. Jain, as you mentioned, selinexor and others, but I want to take this platform as a call to action to our colleagues everywhere. Let's keep identifying new targets. They might be old ones that have already been there in the other myeloid malignancies, MDS, AML, brand new ones that we can get together with the traditional sequencing, and then super new ones, Mohamad, with Adam Mead, Daniel Royston, and the group that Claire mentioned, her colleagues in UK, that are looking at spatial reasoning, AI, all these different algorithms. There's things that are hiding in plain sight, and I want us to find them together.
Fantastic. We'll check in the next few years about these predictions. Ruben, your predictions.
I predict that we're going to learn from our the best responders of our therapies from the recent past in terms of JAK inhibition to gain further insights as to, why did certain patients do incredibly well, and then why did they not progress, and then be able to leverage that to a much greater degree. I think we will validate that splenomegaly and symptoms have been, at least had good correlation with overall progression-free survival and probably overall survival. And hopefully we'll gain further insight that will drive us toward, further combination approaches. Clearly from your field of myeloma, I think we use 9 drugs at the same time now, in myeloma, and I'm not sure whether we'll get to that point, but I would love to see us really be able to evaluate in a strategic way both the combinations and the response. I don't think it is feasible to be trying to sort all of that through mix and match phase 3 trials. To too few patients, there's just not enough numbers to really sort that out well, and that's way too empiric, I think, for our patients. People had criticized the pelabresib and navitoclax data that might they not have been better. I shared with them of the probably over 40 combinations that we have tried since the approval of ruxolitinib. They are by far the most active combinations we have had to date, beating out all those others. So it clearly is incrementally much stronger, but we need to learn more. And without question, I'm really excited about mutation driven therapies, although certainly, mindful, we need to see the responses and the safety before we get ahead of ourselves, but very excited to see that evolve.
So you mentioned myeloma. I can kindly remind you that we have already 2 drugs in common. Venetoclax is, of course, being tested and used in MPNs, and it is in myeloma, the translocation 1114 entity, but also selinexor, which is approved in myeloma, although we've been struggling with the dosage.
And Mohamad, throwing back my older hat, there's a paper Vincent Rajkumar and I wrote 100 years ago on patients who had both MPNs and myeloma. And again, we had many drugs in common. The IMiDs, the anti-angiogenesis drugs. You remember the era of Biaxin, where we were using Biaxin to try to treat.
Pomalidomide was tested in myelofibrosis.
Pomalidomide, lenalidomide. Oh, yeah.
Mohamad, the viewers can find that citation, Rajkumar Mesa, 1897. It's available on microfiche only, okay? So not on.
No. Okay. Any last words, Claire?
Oh, I get the most difficult job. Well, great discussion. I would like to see a lot more data sharing and patient engagement here, right? I think we should be able to delve into the data we generated from these trials. Yes, look at best responders. I'm super excited for combos with our other JAK inhibitors. I think especially momelotinib could be good. But I would like us, I'm just thoughtful of data because I'm also leading the data strategy for our trust. And I think this is a rare disease. We're unlikely to do a platform study with multiple pharma participants, but could we not generate avatar control arms or, a real world data control arm for these studies? As we saw in T2 and Manifest, T1 and Manifest 2, actually the ruxolitinib responders were very similar to Comfort 1 and Comfort 2. We know what control arm does. I think this is something we should be thinking about.
Any last words? Well, you've been absolutely perfect. We're perfectly on time. It's 15 minutes past the hour. I hope everybody has enjoyed this lovely discussion. It's quite incredible the advances we see now in this field. Again, as I said, this past, present, and future, it took us almost 50 years to move from the MPN initial description by Jean-Jacques, then 2005 JAK2 identification. Then 10 years later, almost CAL-R, and now we're talking about SHIP and all of these new targeted treatments. So thank you, Claire. Thank you, Tania. Thank you, Jean-Jacques. Thank you, Ruben. Thank you, Naveen, for sharing your knowledge, your expertise, your wisdom. We're very grateful. I do apologize for all the colleagues. We couldn't take all the questions because, you know, it's not always easy to harmonize or structure an open discussion like this. But I'm sure you can reach out to the speakers and faculty in case of anything burning. So thank you all, wherever you are. It's still time, at least in France, to say Happy New Year and best wishes for a successful and healthy New Year. So wherever you are, please stay safe, keep well, and see you actually tomorrow for another post-ASH dedicated for transplant and cellular therapy. Take care.